Good morning, everyone. I am Dr. Moldizier, Director of the Brockton Public Health Department, and I am here today with my team, and we have a special guest joining us also. So we're going to do a brief presentation at this time, and then we come back to start our program today, which is focusing around tuberculosis. First, as I said, I am Dr. Moldizier, the Executive Health Officer for the City of Brockton. And today we have the great honor of welcoming Dr. Kelly Holland, who is a primary care physician in a different municipality, but he's here with us because he has some special presentation to do with us on TB. So welcome, Dr. Holland. Would you please introduce yourself and where you practice, please?
Yes, of course. And thank you all for having me today. I am a family physician, and I work at the Lynn Community Health Center just north of Boston in primary care. And this being the week of World TB Day, I'm glad to be here with all of you to talk about tuberculosis and some of my experience as a physician and what we see in our health center and what's happening with tuberculosis around the state and the world.
Thank you, Dr. Holland, and we're glad to have you today. Just before we go on with the segment involving you specifically, I'd like to introduce my team also. First, I have to my left Dr. Sebastian. I will let him introduce himself, and then everyone with their title and the place of work.
Good day, audience. I'm Dr. Victor Sebastian. I'm a public health physician and also a medical epidemiologist with the Brockton Board of Health.
Thank you.
My name is Mary Charles. I am one of the CHW for the City of Brockton.
Good morning. My name is Jasenia Ria, and I'm a community health worker at the Brockton Board of Health.
Good morning. My name is Eunice Barbosa Belek. I'm also a community health worker here at the Brockton City of Brockton.
Thank you. Thank you. Dr. Holland, I am so happy that you're here, and I know that our encounter has to do with MASSET. And maybe people say, MASSET, what is that? So MASSET is the Massachusetts Committee to Eliminate Tuberculosis, and that's where we met. And I've been very fascinated with your work and your involvement with the committee. And so therefore, I feel that you have so much you could contribute, particularly around the very topic that we're addressing today. As a practicing physician, and you've dealt with patients who have TB, how is your experience? What has that experience been like for you?
Sure. So tuberculosis, oftentimes people think, especially in the United States, that this is a disease of the past or a disease of other places. And as a primary care physician, it's just not true. It's something that we see, and oftentimes what's difficult is because it's not very common, people have often had many visits to urgent care centers, to emergency departments, to their primary care physician for the same symptoms, this cough that just won't go away, a fever, feeling weak and tired. And they've been dealing with this for months and months until finally somebody thinks, geez, maybe we should be thinking about tuberculosis. And unfortunately, that delay means that the individuals, by the time I see them, have been sick for longer, which within a contagious airborne disease means that they may have inadvertently spread it for longer, and their treatments, regardless of when you were diagnosed, the treatment is difficult, but certainly the sicker a person feels, the weaker a person feels, the harder it is to take these treatments. And so by the time I see somebody with active tuberculosis disease, the healthcare system and not yet gotten that diagnosis, which is very hard on the individual. But we are fortunate that we do have medications to treat tuberculosis, and they are effective, but they're hard to take, which is why I'm so grateful you brought your community health workers with you, because tuberculosis treatment is not a sprint. It is very much a marathon. And tuberculosis also, it never just infects the one person. Their family is often having to get tested, sometimes treated. There are times when people are in isolation. It interrupts a person's ability to work, to support themselves. And so having community health workers to help navigate all of these challenges, even just getting the medicines. Sometimes there are shortages of these medications, and so there are many, many challenges. And I'm thankful for our community health workers because it is often a many, many month process to treat this disease. And I count myself fortunate that we have the tools and the talented people to treat it. But it's never straightforward for our patients, unfortunately.
Thank you. That's a great intro. Would you consider your practice maybe one thing that has been most challenging to you with respect to the demographic that you serve?
Yes, well, most of my patients in Lynn are non-English speaking, and so I can make sure that we always have the appropriate language spoken here in the health center, but oftentimes, especially when they're getting initially diagnosed, we have to send them to the hospital to get maybe some more advanced x-rays or imaging or some additional laboratory tests. And so helping people navigate who aren't familiar with our health system, navigate outside hospitals is very difficult. But honestly, the most challenging is that if I'm telling someone, you're very sick, you can't work for a month, they're more concerned not about some microscopic bacteria, they're worried about rent and food. And it is unfortunate that I wish I could just write a prescription for rent and food as much as I write the prescription for the 4 medications we use to treat tuberculosis. So I think the social piece and the financial stresses our patients face is the most challenging, because I can't order a lab test or give a prescription for maybe what on their mind is the highest priority. Who's going to care for my child? How am I going to keep my job? And how am I going to navigate these hospitals outside of the health center?
Wow. Yeah, so that cuts right through the what we call the social determinants of health, because yes, the person has an infection, but you cannot just focus on the infection alone. There are other ramifications. The social determinants of health, the need for rent, as you said, for food, to care for the rest of the family. Now, one other question I'd like to ask you, you can elaborate, feel free to elaborate whichever way you feel like. What would be maybe the most rewarding experience for you as a physician in that field?
Well, and this is something we can talk about later, but I am a person myself who had active tuberculosis, and I know the impact that it had on my family, on my work. And so perhaps the most rewarding is when someone comes in with this diagnosis, they are very scared. They may be coming from a place where, or their home country perhaps, or have some experience with this as being an untreatable fatal condition. And so it's very rewarding for me to sit across from them. Even though we are masked, I can say, I've been sitting in that seat before and you will get better. We have these treatments. These medications are not easy to take. It's a lot of months to make this go away, but you will get your life back. You will get your strength back, and we're going to support you. And so, because I've had that own experience, I feel comfortable sharing that with patients and saying that that this will not always be the way you feel, and I will make sure you get access to these medicines and can see them maybe relax a little bit and maybe take what I say just slightly more to heart because they know that that I've been sitting on that side of the mask, that side of the experience.
You know, Dr. Holland, when you share your personal experience with us, it makes me so humble to know that any of us can be impacted by an infectious disease and TB. So in other words, TB doesn't have just one face. It does have many faces because sometimes there is a stigma that comes with TB or the stereotyping. And so therefore, I don't know if there's anything that maybe you feel that you could state for our audience around Brockton and perhaps beyond, because sometimes TV can go a long way. So I don't know if there is something you want to add there that you feel that maybe matching faces with an individual who is not a number, but a real person that has an infection that he or she has to deal with on a day-to-day.
Yes, and I'm so glad you mentioned stigma, Dr. Mondesir, because there is a lot of stigma, a lot of fear around having this diagnosis, a lot of secrecy. And so because I have a lot of privilege, I try to be very open about my experience with tuberculosis because this is an airborne disease. So you cannot isolate yourself from the shared air that we all breathe. And so we all need to care about tuberculosis because this is something that really can impact anybody. And as a physician and a human being, I want to treat tuberculosis because it's the right thing to do. And nobody should have to go through this experience when we have the tools to treat it. But certainly, because we all share this air, I mean, truly, tuberculosis in any part of the world is tuberculosis that can impact all of us. And so as we all share the same air, we need to be really mindful and caring about what is in it, including tuberculosis.
Well, Dr. Holland, I am humbled that you have answered positively to participate in this great presentation. I'm going to ask you another question, and then after that you can feel free to stay on and watch, or if you prefer, that's okay. You can sign off whichever time you feel like it. If you had one advice that you would like to leave on this show for providers and for maybe people who are struggling with TB right now, who have been told that they have TB, what would that advice be?
Sure. So for my fellow colleagues who are clinicians, I would say two things. One is you have to think about tuberculosis, because if you don't think that it's here in Massachusetts, if you don't think you need to care about it, then you're going to be missing those cases. And people who are coming to see you are going to be sicker for longer because we didn't think about it. So we must, as clinicians, always think about it and know it's here. And then the other thing I would say to my colleagues is make sure you aren't just looking at the patient, that you are looking at the people sitting next to them or the people who are in their home, not just for the contact investigation, but also because this diagnosis impacts the entire family. And that we need to be educating and supporting, not just to say, take your pills, although that is important. People do need to take their medicine, but also we need to be asking them, How are they holding up emotionally, being isolated? Are there social determinants that we need to consider and really look at the whole person? Because this mycobacteria does not just affect the lungs, it affects many parts of the body, but also many parts of a person's life. So don't just look at the x-rays or the sputum sample, but look at that person and their family as you're dealing with this marathon.
Thank you so much, Dr. Holland. And now we are bringing in the rest of the team to continue the presentation on reimagining TB, because TB is with us, and so therefore we need to address it, as you have heard during the presentation with Dr. Holland. So TB is here with us, and we need to really address it and put it with a face, and perhaps sometimes not just one face, but other faces that relate to that one face that is physically impacted by the infection. So now as we go, I will start with Dr. Sebastian, and the rest of the team, but we're going to take a brief pause and then come back in a short while. Hello everyone. This is the presentation by the City of Brockton Health Department, and I am Dr. Ino Mondesier, the Executive Officer for the City of Brockton Health Department, and along with me, I have...
Good afternoon, audience. I'm Dr. Victor Sebastian, a public health physician and a medical epidemiologist with the Board of Health, Brockton, City of Brockton.
Today, we bring a topic that is very salient, a topic that we are dealing with presently. And so as you can see on the screen, we say tuberculosis, or for short, TB for short, a re-emerging disease in the United States, a re-emerging disease in the United States. Many people may think that TB is a thing of the past, is an infection of the past, but our experience shows different scenario. And so we want to bring this to everyone in the city of Brockton so that you'll be aware of the TB in the United States and also in the city of Brockton. And so we are going to give you a very broad perspective of the disease, how to deal with it, what it is and what it is not, and how to best handle it, and how to also support people who may be impacted by it. Tuberculosis is caused by bacteria that we call bacillus, and right there we have we can see on that picture there the long slanted rods. They look like rods, but that's a picture of the bacillus. And the bacillus itself is called Bacillus of Koch because the physician who discovered it, his name was Koch, so they basically called the Bacillus of Koch. And many people think that tuberculosis is simply a disease that can affect one organ of the body, and namely the lungs. While this is true to some extent, but TB can impact any organ in the body. And so therefore, I am going to let Dr. Sebastian do a little overview of TB, his experience as a physician and medical epidemiologist. Dr. Sebastian.
Thank you very much, Dr. Ina. Yes, as it has been mentioned, TB is no more a disease of the past. We, from experience, we're beginning to notice that TB is present here in the United States. And as Dr. Ina had said, TB is a disease caused by a germ that medically we call Mycobacterium tuberculosis. It affects most of the time the lungs. And so once people hear of TB, they immediately think of only the lungs, but it also does affect other organs of the body. Other organs of the body that can be affected include the bones, the lymph nodes, the brain and the covering of the brains especially, the intestines, and then of course indeed any other organ that is exposed to the germ. But commonly, other than the lungs, the places where we usually see TB are in the bones, the lymph nodes, the intestine or the gastrointestinal tract, as we want to call it, and then the brain and the covering of the brains. Yet, in addition to this information, we want to bring to your attention how TB or how anyone can be exposed to TB. Primarily, the means of exposure to TB that is contagious is the air. In other words, therefore, it means by what I've just said that are some types of TB not contagious? Truly, some types of TB are not contagious. TB that is present in any other organ of the body other than in the lungs is not readily transmissible. So, but yet those other organs of the body can get affected by means that are other than the air, such as by ingestion, that is eating contaminated meat and dairy products can cause TB, especially of the intestines. Having an injury from a penetrating object that is contaminated with TB can lead to a TB infection of other parts of the body that is not necessarily transmitted through the air. Having TB transmitted to an organ through the bloodstream and settling in that organ, which we call seeding, can also lead to TB affecting other places other than the lungs. These places that are outside the lungs, we generally call extrapulmonary TB.
Now, while we're there, as we talk about the lungs, basically, this is the most recognizable TB, or the one that sometimes people think about. And this is the one that when people speak or cough without covering the mouth and nose, that the droplets can spread in the air or project towards a person in close proximity. Would you like to maybe elaborate a little bit more on this aspect?
Yes, most TB is in the lungs. And if TB is in the lungs, then the risk of transmitting it to another person through coughing or sneezing is increased. But even then, that risk is not absolute, because not all persons who have TB in the lungs have TB in their aerosols, in their
Saliva?
phlegm, in their saliva, and those. So most of the time when you approach a clinic, your sputum sample is collected and it is tested. If you're having a cough, it is tested for the presence of the germs, the TB germ. If the TB germ is present in that sputum sample, then it likely can be spread to another person. If the TB germ is not present in that sputum sample, either because of the nature or the type of TB that you have, or because your body has been able to mount some immunity and your body has been able to contain the germ extensively, and the germ cannot be found in your sputum, in the cough, then the likelihood of transmitting it to another person is greatly reduced. So persons who have lung TB automatically will not transmit it to another person if those TB germs are not present in their cough sputum, in their coughed off sputum, and therefore not present in their sneezes. Maybe because on account of treatment or on account of the nature of immune response that the body has mounted to it. So that is, so it means therefore the fear that, once somebody has a TB is going to transmit it should be mitigated by our understanding. If somebody has TB and is already on treatment and the TB has been cleared sufficiently that it can be present in the sputum, the chances of transmitting it is even much more reduced. And of course, if somebody has TB in an organ other than the lungs, the person cannot transmit TB. If somebody has TB in their bones, they cannot transmit their TB that is in the bone because they sneezed. No, not at all. If somebody has TB in the lymph node, they cannot transmit that TB to another person because they sneezed. No. The extrapulmonary TBs are not readily transmissible. The TB of the lungs can be transmitted if it is present in the sputum.
We continuing with our presentation on tuberculosis, or TB for short. Dr. Sebastian, we're looking at the types of TB. What can you tell us about types of TB?
Yeah, there are basically two states of TB in the body. A situation in which the TB, when someone is exposed to TB germ, as I've said, two things can happen. One, the body contains it very well and there's no disease breaking out, in which we call it latent TB, or the TB germs overwhelm the body and then there's an active TB disease. Now, latent TB is what you have when, for example, somebody is vaccinated with TB germs. The vaccine usually called BCG, we'll talk about that a bit later. So the body contains it very well. The germs are present in the body, but they are not causing any disease. They are rather being used by the body to produce and to develop an immune response. That's latent TB. It's not a disease state. It's not transmissible to another person. The person has no symptoms. Now, active TB is another state in which the germs have overwhelmed the body. The person is having symptoms. There is coughing, there is swelling, there is fever, there is pain, all those other things that go on with that shows that this person is ill.
Mm-hmm.
So that is active
yeah.
TB.
So you have just dive into some of the symptoms, and I think this slide here also can show us by sign what different sign and symptoms that people with TB can experience.
Yes, people with TB, if it affects the lungs, they will be coughing. There will be cough. Usually the cough is a prolonged cough that doesn't amend itself to regular routine treatment. So usually we'll ask for a history of cough that has been up to 3 weeks and above, 2 weeks and above. You really don't need to wait until the 3rd week. But if you have a cough that has now availed treatment for over 2 weeks, approach your physician and bring it to their attention. Usually also this kind of cough, if the TB is affecting the lungs, may also bring up blood when they are coughing. And there may also be chest pain associated with the coughing. Now, whether the TB affects the lungs or other parts of the body, there usually is a feeling of being weak, no appetite, fever, night sweats, weight loss, because TB tends to be a prolonged disease, but weight loss tends to set in only towards the terminal parts, towards later. So the usual 4 symptoms that will be noticed if it affects the lungs is a cough. If it doesn't affect the lung, there will be swelling wherever that affectation is, or a deformity of that place, an abnormal shaping of that part of the body. So if it's in the intestines, you might notice some kind of bloating or abdominal swelling. If it is in the spine, you might notice a deformity of the spine. If it's in the bone, you might notice pain in that bone, a deformity in that bone. If it's in the lymph nodes, a swelling of that lymph node, pain in that lymph node. Then the other general symptoms of fever, of night sweats, of being weak or fatigue will also be present.
Mm-hmm. And we can also consider symptoms that are not so common. Maybe could we pick up maybe on a couple?
Those symptoms that will be not so common will depend on that. They will feature when the TB is not in the lungs. So, and commonly the TB is in the lungs. So these other symptoms that feature when the TB is not in the lungs are not common, and they will depend on the part of the body that's affected. If it is the lymph node, depending on which lymph node, usually it is the lymph nodes of the neck. We call them cervical lymph nodes. Those lymph nodes will be swollen. You see swellings below the chin bone, between or around the neck. A swelling around the neck may be a lymph node swelling that is due to TB, Not all swellings on the neck are TB, but that should be one of the things that should be suspected and tested for. Then if it is in the intestines, usually from people who drinking contaminated dairy and dairy products, contaminated milk, for example, contaminated beef, dairy products are contaminated. Unpasteurized milk is a very high risk factor in this case. The TB, there may be abdominal swelling, there may be diarrhea, there may be problems with digestion, there will be discomfort in the abdomen, basically, if it affects the abdomen.
Okay. Now, let's talk for a moment about risk factors, including comorbidity, which is basically co-infection.
Okay. Now, the things that will make somebody to be at a higher risk of developing TB are, one, if you live in close contact with somebody who has an active lung TB, that the risks are increased. If you live, or if the person affected is, or if there's a weakened immune system due to HIV, for example, due to malnutrition, due to chronic alcoholism, due to other debilitating illnesses, or any immunosuppressed states that may be consequent to treating some other illness, for example. So people with weakened immune status, a weakened immune status is a risk factor for TB. People who abuse substance, I've just mentioned chronic alcoholism, because generally those also are predisposed to TB because they weaken the body's immune system. People who smoke, people who drink raw unpasteurized milk, if the cattle is infected with TB, it could be, the germs could be present in the dairy products from such arising from such contamination, which usually are milk, meat, or beef. And in that case, if it is not well cooked or pasteurized milk, so there's a danger in drinking unpasteurized milk. We know it is it's becoming a fad these days, but that danger should be emphasized. That there's a danger in drinking unpasteurized milk because it could actually cause abdominal TB.
Okay, now let's move ahead, and we're looking at diagnosis and treatment of active TB. If we look at the science around TB, it's well documented, and so we have all that we need to know in order to diagnose and also to treat TB and even eradicate it. The state of Massachusetts, we have this body that they call MASSET, which is an acronym for Massachusetts Committee to Eliminate Tuberculosis. So I said this to say that when we look at diagnosis, moving from diagnosis to actual treatment, let's tackle this. Let's share with our audience the steps.
When there's suspicion of TB, for example, if the person is coughing, the first things that will be done will be a request for the person to produce sputum, and the sputum will be tested for the presence of the bacteria. Then also a skin test can be done, but the limitation of a skin test is that if the person has been previously exposed, a skin test may be falsely positive. If the bacteria is present in the sputum, it helps in confirming a diagnosis of TB. If the bacteria is not present in the sputum, it does not rule out TB, but it also helps us to know that even if there's a TB, it may not be transmissible to another person. Then other tests that will be done to help reach a conclusion will include various nucleic acid tests that are done through the blood, and then of course also a chest X-ray if the complaints are chest related, if there's a suspicion of a lung or pulmonary TB. Now, if it is from any other organ of the body, for example, if it is lymph nodes, Then what will be done is an aspirate of the lymph node will may be tested. If it's in the bones, the x-rays of those bones, and if there's any collection, an aspirate of that collection will be tested for the presence of the germ. So those basically are the kind of tests that will be done to reach a conclusion if this is a case of TB.
Okay, thank you. While we're here, there's something maybe I could briefly mention around the treatment, because there is also what we call resistance, TB treatment resistance. So while we know that there is a protocol that people must follow from the time they initiate treatment and all the way to the standards set by the clinicians. So along this line, what happens if someone does not complete the treatment as prescribed?
Thank you very much. Usually the treatment of TB is designed in a way to be effective and also to contain the germ. So most of the time, if you have a TB, if a person has TB, the person will be prescribed a cocktail of antibiotics. Now, some 4 or 5 antibiotics, some 4 antibiotics. Now, we encourage people to judiciously and use these antibiotics for the duration of time that they were prescribed to use these medicines. Usually it will be for months. So please do use your drug for months. The TB germ is a difficult germ to treat, unlike other antibiotics that you use basically for a week or less. In the case of a TB, treatment of TB is in months. So we encourage you to strictly abide by the cocktail that has been prescribed for you. Non-abiding with that cocktail, in the sense that not using the drugs consistently, could lead to a situation in which that cocktail, the regimen of drugs you are using, will no longer be effective in containing the germ. And this is a situation where we call TB resistance. In other words, one or more of those components of the drugs that are being used, especially the rifampicin or the INH, are no longer, isoniazid is what I mean by INH, are no longer effective for treating the active TB in this scenario. So that leads to a situation that is called TB drug resistance.
Okay. Okay, so we talk about diagnosis, we talk about treatment, but also there is another chapter that we can look into. And there is a model, not model per se, but rather a statement, a quote from World Health Organization that I like to use a lot, where this says, an ounce of prevention is better than 100 pounds of cure. So I like this very much. So now, let's tackle prevention, because I think all of us can do much better if we can prevent than treating a disease. So how about if we touch on prevention for a little bit so that our audience can really know what to do and how to prevent themselves?
Yes, pulmonary TB or TB that affects the lungs is contagious. So the best way to prevent it is to avoid close contact with persons who have an active lung TB. That will help in preventing that. Then the other things that could also be done, because it's a disease of contact, you avoid congestion. Any person that has active TB should not be in a shared space with many persons at a time. So that helps. So avoiding close contact with people with active TB. Then, of course, also, as I've mentioned in the earlier discussion, the immune status, anything that boosts your immunity will help you to prevent TB. So good diet, exercise, good sleep, all these things that boost your immunity helps you to prevent TB. And then, of course, also medical attention if anyone is experiencing any symptoms that may be or not due to TB, because if it is detected early and the treatments are initiated early, then morbidity is also reduced. So basically, it can be summarized as avoiding close contact, avoiding congested environment, boost your immunity, eat well, sleep well, good diet, good rest, good exercise.
Thank you.
Boost your immunity.
Now, as part of the protocol for prevention, most countries around the world have access or have a way to diagnose TB or to prevent it. And one best way to do that is by vaccination. So could you elaborate a little bit more so on the resources available to do prevention on around
Yes.
vaccination?
In parts of the world where TB is prevalent, then it is cost effective to embark on a immunization scheme to prevent a lot of the population from getting TB. In the United States, TB vaccination used to be done. Vaccination for TB used to be done in the past, but it was stopped since 2005 because TB is not that prevalent in the US. But in environments where TB is prevalent, or if you're visiting an environment where TB is prevalent, it may be advisable you get a vaccine for TB, and that vaccine is called the BCG vaccine. So it's a vaccine that is used in places where TB is prevalent. It's particularly very effective in children, and people that are going to visit such high-density environments are well advised to take that vaccine. If you're going to relocate and live in such an environment and you've not previously been vaccinated, it's highly protective for persons, especially children. Now, one other thing we need to note about this vaccine is once you receive this vaccine, you will always test positive for a skin test for TB. You will need to bring this to the attention of your physician or any person treating you that you have been previously vaccinated with BCG for whatever reasons, either because you were going to relocate to an environment in which TB is prevalent and you took it as a preventive measure, or because by the reason of your age, you have lived in the US at that time of life when you were vaccinated. So if you've been previously vaccinated with BCG, a subsequent skin test for TB will always come up positive. You will need to bring it to the attention of your care providers that you were previously vaccinated with BCG because either you lived in that era or you visited an environment in which TB is prevalent and therefore you needed to protect yourself and you availed yourself of the vaccination.
Yeah, and also that's the reason why sometimes when people go to the physicians, say one person has a preliminary test, maybe a skin test or an X-ray, they may ask for more tests to isolate or to make sure that this person doesn't have an active TB. Sometimes people may say, well, I did this, I did that, and they're sending for more tests. But there is a reason why they do this, and I think this explains the reason sometimes the clinicians do have to require more tests to make sure that the case, that the person they have in front of them is not an active TB, but rather latent TB.
Yeah, very correct. If a skin test is positive for TB, it is not conclusive that that person has TB. If you can isolate germs in the person's, if the person is coughing in the person's sputum, then that may be more conclusive that the person has an active TB. Again, any situation of previous exposure to TB will cause an immune response that will always show up as being positive skin test, either because of vaccination or because of a previous exposure which the body successfully overcame.
Yeah, thank you. And also, if we look at maybe data, sometimes data can help us to know where we are, and that is, in fact, that is the reason why we're talking about re-emerging disease. Because if we look at data these days, we can see the going back years, maybe 20 or so years, we can see the what we call the incident rates. The incidence rate basically tells you how many people in a population is impacted. And then when you go, I mean, from 20, 30 years down through the years, you can see the improvement. And then at one point again, when you look at the incidence, then it's very factual. It can tell you whether or not you're going up or you're going down or you're stagnant. And so right now we can say that basically based on the rates that we see, then we can in fact talk about re-emerging.
Yes. Post-World War, that's post-1945, for example, TB was a major problem in developed as in Europe, in many countries actually, including the United States. But with the improvement of circumstances, the social living conditions, income, nutrition, availability of treatment, and vaccination, the incidence of TB the prevalence of TB has progressively declined. In the United States, for example, if you look at the chart that is before us, this is data collected from CDC. You would see that in the 90s, there were double-digit thousands of cases of TB in the United States, as high as 25,000, but progressively it declined. And by the year 2008, we could see that it really came down to much less than 15,000. Mm-hmm. Sometimes it even went just a little above 10,000 cases in the entirety of the US. There were times when we had so much reduction that it was even considered that vaccination to prevent TB was not really necessary. So the BCG vaccine was taken out of the schedule. But presently, not that we're advocating that the vaccine should be brought back, but presently data is showing us that post the pandemic, the number of TB cases are on the increase. Post 2020, the number of TB cases have been on the increase. So this calls for increased awareness, increased caution, and better understanding, so that with good understanding, people can protect themselves, relate appropriately, avail themselves of treatment, and not entertain unnecessary fears.
Yeah, and also we must mention that TB is a major public health threat yes. because of the way that it is transmitted. And also, we cannot talk about TB in a vacuum. We can address it within the environment where people live, because people live with other family members, they live with other needs, and sometimes they have to prioritize those needs also, so that we talk about determinants of health. Yes. Social determinants of health can be anything that may prevent someone from maybe accessing health, or maybe from having the resources available to care for immediate social needs. And not when those needs are not met, then they could lead to risk or to exposure to infection. So how could we inform our public also of those social determinants and public health risks with TB.
Yeah, thank you very much. Yeah, TB is, as you have mentioned, is a social disease in the sense that you need contact with other human beings. You need certain situations to make it possible for this germ. You need good nutrition, protects you. So a situation of poor nutrition, poor income would affect access to quality of living, housing. It will determine the number of persons that live in a space, you know. So to prevent TB, a holistic approach need be adopted. One, good housing. Situations of incarceration, for example, has been known to increase the occurrence of TB among the incarcerated people. So we need a situation in which people have quality housing, access to ventilation, space, sunshine, good nutrition. All this overall will boost the communal resistance to TB. And of course, on the individual level, the good nutrition, the avoidance of contact with persons with active TB, those are individual factors that one can take. But on a communal basis, we need to really improve quality of life, housing, access to number of persons that are in a space, ventilation, good food, pasteurized milk, you know, uncontaminated food and food products. So these are things that we can do on a general communal basis. And the things that can be done on the individual basis are such things as I mentioned earlier on.
As we come closer to the end of this presentation, we cannot but address TB on different geographical levels. TB worldwide, TB in the United States, and TB in Massachusetts. We might say, fortunately, we have resources around the world. We have World Health Organization. What would your recommendation be in terms of working together, public health bodies, not just around the world, but we in the US and in Massachusetts, working together to be able to bring this disease, this infection under control?
The United States has a fantastic infrastructure already in place to contain TB. The US CDC is doing a fantastic job containing TB. Massachusetts has a fantastic state program that is working to actively provide treatment and support to persons who have TB. So the US is fortunate to have a number of resources that are already in place. So if you have any suspicion, just avail yourself these resources. Help is available. Non-stigmatizing help is available anywhere in the US, especially in the in the state of Massachusetts, and of course also in the city of Brockton. So contact information will be available on the screen. You can also contact your local Board of Health, the City of Brockton Board of Health, or perhaps if you're hearing us and you're outside the city of Brockton, your local Board of Health can easily connect you to care that is available within Massachusetts. And if other resources are needed beyond the state of Massachusetts, they are well available within the US CDC. And of course, the WHO externally is also doing a lot of work with a lot of support from the US government. WHO is already doing a lot of work trying to contain TB in many other countries. And we hope this support to the WHO can resume. And also, even other than WHO, the United States government has been supporting a lot of other organizations around the world to fight TB in many different countries. Limited scopes of support, but yet those are focused, effective supports which we are aware of is readily available in the literature that the US government is already supporting, and we hope and we pray that such supports to under-resourced countries will continue.
Well, we have given a lot of information, so I think this is a moment to take a brief pause, and we shall return.